Welcome to EJournal Club. I'm Dr. Leonard Calabrese, Professor of Medicine at the Cleveland Clinic Lerner College of Medicine, Director of the R.J. Fasenmyer Center for Clinical Immunology, and thanks for joining us. Those of you that have been with us before recognize that I select articles not necessarily by anything other than what really interests me and what I think would interest you. And today, a recent study entitled Effects of IL-6 Receptor Blockade on Surrogates of Vascular Risk in RA, the MEASURE trial, a randomized placebo-controlled study. And I have the first author of this, Iain McInnes, a grand friend, and certainly someone who needs no introduction in the rheumatology world as a professor of medicine and rheumatology at the University of Glasgow. So, Iain, welcome to our show.
Well, thank you, Len. It's a real pleasure to join you, and thanks for highlighting this study, which I put together with my very dear friend and colleague, Professor Navid Sattar, here in Glasgow, and was able to conduct and analyze this study with the other co-authors whom you see, who are both learned and were enormously active in the conduct of the trial. So the background here is very simple, and it is that when the IL-6 receptor blocker tocilizumab was first introduced, it became very obvious quite early on in the trial development program that after administration of the drug, there were elevations in total cholesterol and also in cholesterol subunits. And that raises the very obvious question as to whether this is good or bad, because conventional medical wisdom is that elevation of cholesterol will eventually transcend itself into some kind of vascular risk profile. Now, the other element here that you should bear in mind in reading the paper is the very large evidence base we now have that people with rheumatoid are at increased vascular risk, and that people with rheumatoid arthritis actually do not have normal regulation of their lipids a priori. And in particular, we tend to find people with active rheumatoid disease will have, on average, lower levels of cholesterol than we would otherwise expect them to have had. And the current hypothesis is that this is driven by inflammatory factors. So the MEASURE study was a synthesis of this, the opportunity to look at what the impact is of blocking the IL-6 cytokine effect in people with active rheumatoid, and to examine in detail the impact on cholesterol, but also in subcomponents and other surrogates of vascular risk. And you see the objectives laid out very clearly here. The methods are extensively described in the paper. Let me say only that we used NMR spectroscopy to evaluate particle size concentration and a variety of assays, including ELISA and related analyses to measure, for example, the HDL-associated components. I'm showing you here in a slide the basic NMR picture that we derive. And when we just order these tests in the clinic, we tend to think of the lipoprotein subparticles as being very discrete subsets, but in fact they aren't. They're simply a continuum reflecting the size of lipid-containing particles with proteins in there, all the way from chylomicron remnants, VLDL, down to some of the really rather small particles, which are, of course, those of highest density, the HDL. So for purposes of this particular paper, we were interested mainly in the LDL and HDL particles, and also a variant of LDL called Lp(a), shown in pink here. We chose to do a randomized controlled study, and for us it was important to have a placebo arm. So this really is a true experimental medicine study in which placebo and active drug were compared. You see in this stick diagram, patients were equally randomized, 60 per group, to receive either tocilizumab and background methotrexate or placebo and to continue methotrexate. After week 16, we had an escape therapy arm, and from this point, those who escaped went on to open-label tocilizumab. Notice also from week 24 onwards that patients could receive tocilizumab and methotrexate in open-label follow-up. Our primary assessments were at week 12 and secondaries at week 24. And now in a table, I'm showing you the key patient disposition. You'll see that we actually ended up with just a little more than our original predicted number of patients in the study, in the groups concerned. generally well tolerated. 2 patients withdrew from placebo and 5 from the tocilizumab arm, and the numbers shown in the slide here, 27 and 12 respectively in these two groups, entered escape therapy. The demographics of these patients are now shown in this table, and I'll let you cast your eye down them yourselves. You needn't have me read to you, but you'll see that this was a fairly typical rheumatoid population, body mass index elevated, DAS28 in the order of 6.6 for each of the groups. So these people had active disease. Notice also that between 30 and 40% of the patients had also previously received a TNF blocking agent, and just over a quarter of patients were on oral corticosteroids. Baseline methotrexate dose, a respectable 16.8 or 18.2 milligrams per week, respectively. Now, although the primary aim of the study wasn't to determine whether this drug works compared to placebo, let me just quickly orientate you by confirming that, in fact, there was a very robust ACR 20, 50, and 70 response shown, the ACR graph on the left, and on the right-hand side, the DAS28 response in the yellow tocilizumab and methotrexate compared to the orange methotrexate and placebo recipients. And that response was evident by week 12 and sustained through week 24. You see the methotrexate placebo group start to respond, reflecting carryover in the open label early escape. The real interest in the trial, of course, is what happens to parameters of vascular risk. So let me show you a cartoon. Now, don't be disheartened. The grey line in the middle is a notional endothelium. The top above that is the lumen, and below that is a vessel wall containing, amongst other things, macrophages, other inflammatory cells, and adipocytes. What you see, of course, is that in the normal event, and in fact this is a part of normal physiology, lipid particles will cross the endothelial barrier, and if retained within the vessel in an inflammatory context, can then lead to the upregulation of a whole variety of inflammatory markers on the endothelium, that in turn leading potentially to increased cellular recruitment of leukocyte subsets and the initiation or perpetuation of a putative atherosclerotic lesion. So, these are the kinds of things we were interested in. What could it be if lipids were modified that might impact on this pathway? So let's turn now to what happens to lipids. And in this figure, I'm showing you that, and all of the figures that you're going to see in the next couple of minutes are laid out in a very similar way. We're showing the percentage change from baseline in the measure of the parameter shown. And you'll see in the placebo line a comparison with the bold lines that are the actual tocilizumab recipients. So if you look here, you'll see on the left-hand side that large LDL particles did indeed increase by in the order of 20 to 30% upon receipt of tocilizumab compared to placebo. Interestingly enough, and these were new data, the small LDL particles really didn't change when one compares the two groups and didn't really change significantly compared to baseline. Now that's important because conventional wisdom is that it is actually the small LDL particles that will cross the endothelial barrier and mediate inflammatory effects in tissue. So those particles which we believe are most at risk do not in fact change significantly in tocilizumab versus placebo comparison. Moving on to Lp(a) now, and you'll see on the left-hand side oxidized LDA changes, which are very difficult to interpret, in fact. I'm happy to deal with that with Len over questions. But if you look on the right-hand side, you see a dramatic and rapid and sustained reduction in Lp(a). Lp(a) is an independent predictor of vascular risk, and a reduction of this kind has rarely been seen with pharmacological intervention before. Talking very briefly about some of the larger particles, in this figure you're looking at elevation of the VLDL chylomicron and VLDL triglyceride compartments. And you see that, as we would have expected from prior studies, there are significant elevations in the concentrations of these. The functional implication of that is unclear to us at present. Now let me turn to HDL, and to just orientate you, here's a cartoon on the left-hand side, an HDL particle which is normally containing a number of proteins, lipid enzymes, and factors that will regulate inflammation, clotting tendency, and the like. Now, in active rheumatoid arthritis, HDL particles are not the same as when compared with healthy controls. So, for example, they have increased expression of SAA, serum amyloid A, a variety of apolipoproteins are increased, and also phospholipases. And in fact, there are evidences suggesting that the rheumatoid HDL is in fact not atheroprotective. And that's actually quite significant for us as clinicians, because that means the HDL factor that we measure when we're just doing a test in the clinic may not be giving us the same value judgment about overall vascular risk to that patient as it does when we do the same experiment in the general population. Very interesting concept. So what happened to HDL when we gave people tocilizumab? Well, you'll see here in this graph that there was remarkably little change from baseline in large HDL, and in the changes that we've noticed in cholesterol before were almost all manifest in the small HDL compartment, shown in the bold line, an elevation here of approximately 20%, onset rapidly. The earliest time point of measurement was 2 weeks, and sustained through week 24. What was more interesting, and again this was a first for this trial, was that we then went on to look at the subcomponents within SAA. And what you'll see here is that those patients who received tocilizumab as compared to placebo showed a marked reduction in the HDL-associated SAA, a reduction in SPLA2, and an increase in peroxinase. Why should that matter? Well, it turns out that HDL-associated SAA and SPLA2 are pro-inflammatory, pro-atherogenic factors, whereas peroxinase is antioxidant, and its elevation may conceivably revert the HDL particle to an atheroprotective phenotype. Just to be clear, that is hypothesis. We've not proven it in this study. And finally, of course, let's not forget other markers shown to be associated with vascular risk. And in this figure, I'm showing you that there were rapid and sustained reductions in high-sensitivity CRP, in D-dimers, reflecting, if you like, the clotability of the blood, haptoglobin and fibrinogen, other measures of the acute phase response associated with atherogenic risk. So let me summarize the key findings in the MEASURE study. When active tocilizumab therapy was compared with placebo, we showed increases mainly in the LDL compartment in the larger size particles, increases in VLDL subclasses, and in the HDL compartment, increases mainly in the small HDL particles. We actually, and probably even more importantly, found qualitative alteration in the HDL particle composition, which in general moves the HDL back to an atheroprotective phenotype. And we saw a reduction in other factors which are clearly related to vascular risk, for example, D-dimer, fibrinogen, and LPA little e expression. And finally, a cartoon to bring this together. Our interpretation of the trial is that Interleukin-6, elevated in the context of active synovitis, mediates effects on lipid circulation, lipoprotein assembly, and actually, although the total HDL and LDL cholesterols that we measure in the studies showed elevation, it may well be upon more detailed evaluation that these changes are not necessarily a pro-atherogenic risk profile. However, there is a very important proviso, and that is that without clinical trial data and endpoint data, we cannot be confident. And this study is simply a molecular medicine mechanism of action study that gives us information to help us make informed decisions in the clinic. So I hope that's been helpful to you. I'm delighted that you have some interest in the paper, and I'll be delighted to answer any questions that I can.
Oh, most excellent, Iain. A very nice summary of this. And let me preface by saying, you know, I picked this paper. First of all, I've been engaged with these mechanisms, and certainly I remember when this was presented as an abstract, and glad to see it in full manuscript form. I think that tocilizumab was the first drug biologic that rheumatologists have got their hands on, where the cardiovascular warnings and the implications that lipids should be done and monitored. It was the first time that we saw that, and it is not unique to tocilizumab. And and we see this now with tofacitinib and the follow-on drugs in the IL-6 pathway are all kind of reflexively putting out concern about the direction of lipoprotein assays. At the same time, this gives us a very granular view and tells us what we have come to know, that quantitative analysis of lipoproteins is insufficient to give us optimal risk prediction in individuals with inflammatory disease, where there's obviously risk partitioning between many factors, including traditional lipids, reversible factors, and inflammation. And I think that this, in its component parts, gives us some time to reflect. So let me start by asking you a few questions here. You did not discuss this, and you didn't really have time to discuss it, but in the paper, pulse wave velocity was examined. Will you tell us what the thinking was there and what you found?
Oh, absolutely. So we actually learned an enormous amount in the pulse wave velocity part of the study. Let me explain, first of all, why we included it. We were interested not only in metabolic changes mediated by IL-6 inhibition, but there was also a hypothesis that the reduction in inflammation might also lead in turn to a improvement in vascular function. There are a number of studies that have shown, for example, that TNF blockade is associated with, using a variety of physiological measures, in fact, an improvement in vascular stiffness, and that in turn would increase one's confidence. Now, we failed to show that effect in the study, and the reason for that is unclear. Let me explain why it's unclear, because in fact we failed technically to achieve sufficient homogeneity of the methodology across the different centers. This was a multi-center study. In retrospect, we probably shouldn't have tried to do physiology across different sites without far more collation and technical homogenization of our approach, which is why I preface my remarks by saying we learned a lot. That change which we did see was a slight improvement in the placebo arm rather than tocilizumab. Our conclusion from this actually is that we cannot draw firm conclusions. And I think it will be important in time to come to really look at the impact of tocilizumab on the vascular physiology using probably smaller center groups and refined physiologic methodologies, MR-based or otherwise.
I think that points out, vascular surrogates are still a work in progress, and there are a lot of technical issues for that, even following carotid intimal medial thickness over very short periods of time. These are very exacting measurements, and a lot of quality control is needed to make them a robust endpoint.
Oh, absolutely. I couldn't agree more.
I particularly was interested and impressed by looking at HDL. I think that too many physicians have, we've been kind of presented with this good and bad cholesterol notion, and patients, this is very common in patient disease awareness. They know their numbers, but it is in patients with inflammatory disease, as this paper points out, it's a far more complex issue. And the real HDL is a highly complex protein, over 50 proteins, and with antioxidative functions, immunomodulatory functions, anti-inflammatory functions. You picked out some of the important ones. Peroxidase is one that is really kind of coming to the fore. I know that our group, Elaine Husney and Stan Hazen, have been looking at actual enzymatic activity as opposed to looking at it antigenically, and have found perturbations in peroxidase not only in rheumatoid, but as you're well aware, psoriasis and psoriatic arthritis. So this appears to be an issue for broad-based inflammatory diseases?
Yeah, let me just pick up on that point. So, actually, first of all, the data that you're describing sound utterly fascinating. We, for a whole variety of reasons, elected to look at the antigen reporting assay rather than enzymatic activity, and it's particularly when you're thinking about cytokine-mediated metabolic function, understanding enzymatic activity as well as presence of enzyme is really critical. Two things just to, first of all, to confirm and extend your thoughts. This goes, I suspect, well beyond rheumatoid, psoriasis, PSA. There's now very good evidence of metabolic dysfunction in psoriasis and PSA, and in fact, it may be even more of a feature in that disease state than in rheumatoid. Just to point out the paradox before anyone does, if you're reading this or listening to this and thinking, you know what, hang on a minute, CRP doesn't go up in a lot of my PSA patients. How does that figure? Well, I think what it says is that there's more than IL-6 operating here. So in fact, by trying to understand the extended paradigm across psoriasis and PSA as well as rheumatoid, we'll actually start to really drill down on the complexity of the way in which the metabolic syndrome and the immune system have crosstalk. So it's a great point, Len, and it allows me just to put a qualifying mark on the measure study. In no way are we suggesting that IL-6 is the only or dominant regulatory partner here.
Let me close with asking you to comment on one area, and then I'll try to get some provocative comment from you. So would you like to just talk to the listeners about reverse cholesterol transport and the challenges of measuring this? And it sounds like a natural thing that we want to be looking at.
Yeah, by all means. So reverse cholesterol transport is the process whereby esterification occurs and cholesterol is moved from peripheral tissues to the liver, where it can then be excreted through the bile into the gut. The concept, and actually we've used tofacitinib as a molecular tool to explore the biology of this in a little bit more detail, and we published that work recently also. Let me try and give you a mental picture of how this works. We strongly suspect, in the context of active inflammation, that cholesterol trafficking is in some way interrupted such that there is enhanced clearance of cholesterol that is coming from the periphery to the liver, and that in turn is cleared. Now, imagine the scenario when you then introduce an inflammation-blocking agent like tocilizumab, and we'd actually do see elevation of cholesterol with TNF blockade, although to a much lesser extent. One of the things that will then happen is that the hepatic receptors that lead to uptake of lipids may well be downregulated very quickly. We've actually shown that in a couple of other studies. So in a sense, what you have is the periphery continues to put cholesterol into the circulation, but the cholesterol is not taken up by the liver in the same amount. And what that then means is that cholesterol and its surrogates within particles and the like could theoretically back up, and you see almost like a dam effect, and the levels rise. And that, therefore, is why we see the changes, rapidly onset, I may say, in cholesterol levels in people after anti-inflammatory therapy. Now, what I've given you is a hypothesis. We do have some radio-labeled lipid data that are consistent with that. We also have a further trial, Len, that I'll be really excited to tell folk about later this year, the Calabrese study, in which we've used tocilizumab and radio-labeled lipid tracking in patients with rheumatoid arthritis to really nail down the impact of IL-6 on reverse cholesterol transport. So we're just analyzing the data at the moment, so I can't tell you quite how it worked out.
Is this a total body system?
Forgive me? It's inpatient.
Total body system?
Yes, it is. It's in patients, and it's using a rapid removal of cholesterol from numerous samples from patients over 1 week after receipt of their of their tocilizumab. So we're pretty excited about that. It's going to be cool. It was a very labor-intensive study for our patients. We owe them an enormous debt of gratitude, but we'll be reporting on that later on. But the initial signs we have, as I say, from the TOFA study is that there are indeed effects in reverse cholesterol transport, and there may be effects on hepatic uptake of cholesterol, which is why we get this fairly rapid interactions between cytokine blockade and measurable cholesterol levels. And the implication of that, by the way, for clinicians, I really like the point you made. What we measure in rheumatoid arthritis peripheral blood may not be directly comparable with how we measure and what we measure in the general population. And we just need to be cautious and smart in the way we make interpretations of those values.
So finally, you take your crystal ball out here, and we are unfortunately locked into assays that we have access to that are reproducible and can be measured with precision. And many of the techniques that you've referred to in your paper and talking about deuterized lipids, these are research techniques. How close are we to, in the clinic, having more qualitative assays that can influence our decision making?
Well, you asked me to be provocative, so I'm going to be provocative. We're still, I think, a long way away from that, and the provocative nature of my comment is that I think we are unnecessarily a long way away from it, and I think that's because as a community we may have been a little slower than we ought to have been in thinking about what the actual biology of biomarkers are telling us, or is telling us, I should say. We actually do know a lot about how inflammation and lipid biology overlap, and yet we accept measurement of a cholesterol from massive population studies and just assume that those will translate across to rheumatoid without interrogation and inquiry. Well, I think we're now beyond that, but we don't have the assays available to us at the moment, Len. We and I think several other groups are looking at a whole variety of NMR-based methodologies to try and find new surrogates that could become useful in the clinic, but it's a little difficult at the moment. It's a little difficult at the moment to think about what is immediately going to be transferable across into useful diagnostic tests. And then, of course, there's an enormous amount of validation to be done. And we don't have the luxury in rheumatoid of large validated outcome studies. So it's going to be very difficult to know what these markers, what these surrogates of vascular risk are telling us about long-term survival. It's taken 10 or 15 years for general population vascular biology to tell us about primary and secondary prevention and the predictive value of biomarkers within that context. So I suspect it's going to take us longer than we would like before we get to that kind of nirvana, which would be a marker that was rheumatoid specific.
Yeah, I hear you. The good news is I think that, one of the observations from virtually all the trials that have come out recently is that cardiovascular event rates are decreasing in our population. And that's probably due to treating to target as well as some vigilance for traditional cardiovascular risk modification. And that's good for our patients. And we're just going to have to wait and see what the next game changer will be in the clinic. So, Iain, I want to thank you so much for walking us through this data in such an elegant fashion. We look forward to hearing about your subsequent studies. For all of those of you out there that have been listening to us, please come back to our website. We have scores of programs on our site. Our recent Biologics 6 Summit is now totally up, over 30 talks. Come back often and join us. Thank you.